This presentation is adapted from Sleep Academy, an online CME-accredited course for advanced practitioners and physicians. My name is Dr. Peter Sloan, and I'd like to introduce Dr. Brian Bonner.
So there are two basic mechanisms that can explain a patient who has central sleep apnea. The first one is that there is hypoventilation, and with that, an increase in PCO2. And the second mechanism is the one that I've just reviewed with you that explains how the hyperventilatory mechanism can cause apnea. And this is explained by blowing the CO2 down to overshoot the apnea threshold and to develop a central apnea on that basis. So these mechanisms are obviously very different. So let's take a closer look at this. First of all, we'll take a look at the patient who has central sleep apnea explained by hypoventilating. So with the central apnea associated with hypoventilation, during sleep there will be a loss of behavioral control, and there will now be a blunting also of the central controls. And there's several different mechanisms by which this blunting or compromise in the central controls can take place. And some clinical examples of this are that the use of opiates, and the mechanism that we're discussing here is one that is very prevalent, where apnea and respiratory failure can occur with excessive use of these medications. There also are diseases of the central nervous system that can contribute to this, sometimes acutely, such as encephalitis or even a large stroke where we lose those central controls. And then there's also some neuromuscular diseases that result in hypoventilation even throughout the day and then become exacerbated during the time we're asleep. So now let's return to that mechanism of hyperventilation and expand on our understanding of this process. So to better understand some of the reasons that we have the hyperventilation that leads to central apnea, we need to explore this concept known as loop gain. And this is a process wherein the controls of respiration are further destabilized because of two features. The first of these is known as plant gain, which refers to the increased ventilation produced by the lung itself. And for instance, a lung that has an acute process such as pulmonary edema or inflammation will cause stretch receptors in the lung to send signals to the brain that respiratory drive needs to be increased. I'm not sure why the term plant gain in terms of the name, but lung gain certainly would be more of a tag to remember as far as the term. The second part of this then is controller gain, and controller gain refers to the central or the central respiratory centers that are sending back an amplified signal to the respiratory muscles. And these two conditions can occur independently, and in conditions such as congestive heart failure, it's also easy to see how the two can occur at the same time. For instance, if the carotid bodies are sensing low oxygen level from CHF, it will send a message to increase respiratory drive on that basis as well. So if we return to our CO2 curve here and look at the influence of a increased ventilation, whether it's from plant gain or controller gain or both, the result will be the same. There's a degree of hyperventilation that will blow the CO2 down to the apnea threshold, and the overshoot of this will cause the absence of respiratory drive temporarily and will result in a central apnea. So now we're going to look at the mechanism that explains why patients with congestive heart failure are prone to having Cheyne-Stokes breathing. And on the foundation that there's plant gain that may be explained by pulmonary stretch receptors responding to a little pulmonary edema, controller gain causing increased ventilation because of hypoxemia. There is one other concept in these patients that is important to understand, and that is that if the patient has congestive heart failure, particularly with low cardiac output, the blood containing the PCO2 will be pumped out of the heart with a reduced ejection fraction, and therefore the signal will get to the medullary center in a delayed fashion. For instance, the transit time that normally takes 10 seconds to pump blood up to the brainstem may be more like 20 seconds or 30 seconds, and the medulla is getting a signal that is late, and this results in an inappropriate and a delayed response. So let's take a look at this from the viewpoint of the medullary center. And the medullary center is monitoring these PCO2 levels, and it is actually confused because these levels are changing so readily. The medulla then is playing catch up, varying the degree of ventilatory signals that are sent to the respiratory muscles, and then followed by periods of slowing down ventilation. So the red line here reflects these resulting PCO2 levels that arrive, and you'll see that there will be a curvilinear shape to the PCO2, and this is going to be affecting the response. For instance, if the period of the ventilation during the higher PCO2 will reflect increased ventilation, as that drops down, there will be a decrescendo all the way down to the apnea threshold. And once the PCO2 is less than that threshold of 36, then there will be no respiratory drive for a period of 10-15 seconds. And then as that PCO2 climbs back up, then the respiratory drive will start to have a crescendo appearance. And so we're going to be looking at a airflow signal that will be similar to the one noted here. So corresponding to the CO2 on the left, there will be a decrescendo in the first part of this. The apnea, which is the 10-second portion of the Cheyne-Stokes event, and this is followed then by a crescendo period. So these will cycle generally around 40, 45, 50 seconds for each of these, and this is the mechanism through which we have Cheyne-Stokes breathing or Cheyne-Stokes respiration. So the number one cause of this hyperventilatory form of central sleep apnea is Cheyne-Stokes respiration, and this occurs most commonly in CHF. And there are a few medical conditions that are associated with this as well, including patients with stroke, renal failure, or acromegaly. There's also conditions in patients who have traveled to altitude and may have already returned from altitude, but this mechanism of central sleep apnea is explained by the lower oxygen tensions at altitude that were telling the chemoreceptors to kick up the signal, which often will drive down the CO2 to apnea threshold. And so below the apnea threshold, there will be central apneas, and this will be problematic during sleep at altitude and may persist for a few days when returning to regular altitude. And finally, there is this syndrome known as positive airway pressure emergent central apnea. And this actually occurs in patients who have obstructive apnea who are on PAP therapy. And the other name for this is complex apnea, and we'll take a look at that mechanism shortly as well.
If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.